Okay, yes, great. It is time to get started, isn't it? So, hi everyone. I'm Dr. Rob McKenna, and I'm from the Health Resources and Services Administration. I'm excited to be here with you today, attending this last day of the virtual conference. I think it's been an awesome one, and I hope you have as well. It's my privilege to welcome you to this session of the conference, Telemedicine Training, the Transformation of Healthcare. And so just a quick reminder, as with all the sessions, please remember that we're using the Event Mobi conference app to take and respond to questions in writing. So please do submit any questions or comments there, and we'll get to them as we can. Today's faculty actually would appreciate some engagement. So you don't need to wait until the end of the session to do that. Post your questions as you'd like. Also go ahead and upvote them, anything you see there that you share in question or comment. Alternatively, if you'd like to speak and let us hear you asking your question or making a comment, I understand you have the ability in this session to unmute yourself. So cautiously do that, please. But go ahead and unmute yourself when you'd like to ask a question, and we'll take it as we can. So with that said, it's my honor to quickly introduce this session's faculty, sharing some of their expertise with us today, both from emergency medicine at Weill Cornell Medicine, New York Presbyterian, or vice versa. We have Dr. Peter Greenwald, the Director of Telemedicine and Telemedicine Quality Assurance, and Dr. Neil Naik, an Assistant Professor. Their fuller bios are both available in the conference app, and in reading them, we're clearly fortunate to be able to learn from them today. So thank you, Dr. Peter and Dr. Neil, for being with us.
Pleasure being here.
Our pleasure. So I'm here today wearing a couple different hats. As was mentioned, clinically, I'm an emergency medicine physician. I'm also an academic doctor for Weill Cornell, which is part of the New York Presbyterian system. And I'm talking about education we're doing primarily through our Center for Virtual Care at Weill Cornell. And I'm joined by Neil Naik, one of my colleagues and an expert in medical education and medical simulation. Next slide, please. So it's been an interesting several months, but we started our telemedicine journey at Weill Cornell back in 2016. I'm going to talk a little bit about where we were, what happened through COVID, and how it relates to education. Next slide now. So I don't need to tell anyone in the audience that telemedicine has undergone a unplanned and fairly rapid transition into the mainstream in the last couple months. I read a paper put out by Ativ Mehrotra at Harvard, who indicated that 14% of medical visits overall were telemedicine visits during the month of April. And in this environment, we obviously have a lot of people doing telemedicine who've never done it before. And hopefully we make the case that training gives our providers the opportunity to put their best foot forward. Next slide. So what we're doing locally. Next slide. Back in 2016, our institution felt that a large investment in telemedicine capacity would help meet what then at the time seemed like would be the near horizon onset of a transition to value-based care, and that through using telemedicine, we could increase patient access, improve outcomes, and potentially do this more efficiently and improve both patient and clinician experience. And again, this is 2016. Next slide. We in the emergency department were early adopters of this institution-wide effort. And I'll just briefly list a few of the things we've been involved with in the emergency department. We developed an ED Express Care model. And this is a model where low acuity patients coming into the emergency department are cared for not by an in-person doctor, but by one of our faculty physicians doing dedicated telemedicine work. A brief medical screening exam is done in triage, and then if you're in the ED for something like a twisted ankle, return to work note, a med refill, you're offered a telemedicine visit instead of an in-person visit. This helps allow our in-person physicians to care for more acutely ill people. It also pulls people out of the regular ED flow that is better designed for more serious illness. It allows us to have a one-on-one direct patient interaction that usually has its beginning, middle, and end in one interactive session, where the physician talks with the patient, goes over a treatment plan or plan to address whatever their problem is, prints out discharge paperwork directly into the room, reviews the plan, and the patient is on their way. Reducing a visit for similar low acuity problems from 1.5 to 2 hours down to about 45 minutes, mostly through getting rid of systems inefficiencies. But these visits can have regular emergency department things happen too, like x-rays and medications if necessary. Although for the majority of our patients, that's not necessary. We have a virtual urgent care service. It's the same physician pool as staffing that staffed the service I was just talking about. And that's probably familiar to just about everyone in the audience. That's using your phone, your computer to speak with the physician on your lunch break from your office, from your home, or whatever other location you choose. We have an interesting telesitter program. I know this is being explored by some other institutions as well. We've actually mounted cameras throughout our ED in the ceiling that have the ability to do not only video but audio interaction. And we have a technician watch patients at high risk for fall, alert clinical staff when behavior looks like it's likely to lead to a fall, but they also have the ability to redirect the patient at the same time. We have a program that is close to my heart. We call it CTP, Community Teleparamedicine. There are different flavors of programs like this being rolled out different institutions, but in this program, we initially focused on congestive heart failure, but have since moved on to several other diagnoses. We send paramedics to very ill post-discharge patients' homes, use the paramedics' hands, their clinical skills, coupled with a physician present by telemedicine, doing things like in the case of congestive heart failure, diuretic management, med reconciliation. And we've seen a very low readmission rate compared to these same patients prior to their enrollment in the program. And we are now in the process of expanding that out to be more of a hospital at home for post-ED discharge patients. Although this is primarily ED physician led, with the specialty services, it's conducted in close consultation with the physicians responsible for whichever specialty, whether it be renal failure, COPD, or congestive heart failure, some of the specialty conditions we've worked with. We also, for those in the emergency department world, we have a telemedicine present provider and triage model, where in this case our advanced practice providers sit and man the intake areas of 3 different portions of 2 different EDs, multiple windows up at once, interact with nursing and with patients on arrival to order needed laboratory testing, x-rays, occasionally do things like initiate sepsis codes, stroke codes right from triage to speed movement forward. We have some other programs as well. We have pharmacists coming into the ED by telemedicine, to name one. Next slide. Our telemedicine work has garnered some recognition. We've received national awards. We've been active in the academic literature. And our new innovative care models have resulted in many contacts from sister institutions across the country and nationally, internationally, in fact. Next slide. So that's where we were, 2016, up until March of this year. And as everyone is aware, things are not looking pretty in the country in several places with COVID, but New York City was hit very hard, very early. Next slide. During the initial wave of COVID, we had a dramatic increase in our direct-to-consumer demand. Visit volume went up roughly 15-fold. At the same time that that happened, we had the hospital basically shut down all elective procedures, and many outpatient environments were completely shut, idling physicians. And this does tie into education. We took this pool of idled physicians and used them to meet the the new demand for virtual urgent care. Now, many of these physicians, and you can read the specialties on the slide here, including things like neurosurgeons, dermatologists, reproductive endocrinologists, were not accustomed to doing acute care medicine, let alone telemedicine. Through a combination of rapid onboarding using webinars, but more importantly, through guiding people through visits with creative uses of communications technology. Basically, one of the things we did was run a Zoom platform on top of our telemedicine platform so that providers could observe virtual visits and then have their virtual visits proctored by a seasoned provider when they did the first couple themselves. It was tremendously successful. We did this coupled with real-time chat group available for all physicians on our platform so that real-time advice could be given regarding patient care. Next slide. Another thing we did, and I've heard this referred to as electronic personal protective equipment, we set up telemedicine carts in our isolation rooms in the ED and workstations right outside those rooms. And these were carts, for the most part, that already existed for other purposes within the hospital. We rapidly onboarded physicians in how to use the carts and interact with patients. So this didn't afford us an initial physical exam, but it allowed us to update patients on their results, inquire as to their status and well-being during their ED stay. In some cases, it allowed us to put family who'd come to visit outside the room and let them interact with the patient, making it so they didn't need to don and doff to go into the room, and just reducing the number of times anyone was in and out of the room. The system was not only used by emergency department physicians, but also social workers, nurses, and we didn't intend it this way, but surprisingly got used an awful lot by our admitting teams who would come down. The entire team would gather around the external workstation, and one provider would go into the room and interact with the patient. This is a whole area that I think warrants further development. Next slide. Another thing we did with telemedicine during COVID is in New York, this whole flatten the curve phrase that's familiar to everyone, we were very concerned about the possibility of our hospitals being overwhelmed. And in pockets of New York, hospitals did become overwhelmed. In this context, we switched over to a crisis care medicine model where we were actually discharging folks who were moderately hypoxic after a minute of exertion in the ED with COVID symptoms. At the time, we didn't have the ability to test people who weren't going to be admitted. But with COVID-like illness, who on a minute of exertion could maintain their saturation over 90%, we used that as a cutoff for potential discharge. Folks with lower saturations, 91, 92%, we sent home with oxygen concentrators, and anyone who couldn't keep their saturation above 95% also went home with a pulse ox. These patients, we used a group of nurse practitioners whose normal job before COVID was doing preoperative screening, and we rapidly onboarded them with a scripted system for doing telemedicine visits for patients we discharged that we did daily for a week. And we followed over 1,000 patients this way with about a 15% return to the ED and admission rate in that group. And we're doing a more detailed evaluation of the data now. But this was a rapid onboarding of a scripted, primarily dyspnea exam, incorporating thresholds of respiratory rate and oxygen saturation at each visit to meet the criteria for either you could stay home or need to be redirected back to the ED. Next slide. Another thing that happened that is interesting, not high volume, but New York City EMS had a dramatic increase in their call volume, and ambulance response times to lower acuity problems went through the roof, up over a couple hours at some point. So New York City EMS reached out to many of the academic hospitals in New York and developed a system to redirect 911 calls of lower acuity into the telemedicine systems of these academic hospitals. And we developed a system for doing this and taught providers how to do this as well. Next slide. One of the things we realized as we were doing this, and we took liberal, what should I say, made liberal use of the waiver of HIPAA enforcement to increase the flexibility of our telemedicine communication, to bring in multiple providers into a single visit. We also started working more closely with scribes to increase the efficiency of our telemedicine systems. What you see on the screen here is, I think, an ideal state where we need to develop virtual urgent care systems where you can have multiple people interact at once, whether that's a patient with their family member who's in another location, whether it's two physicians together, either it being a learning physician and an experienced physician, or a primary physician and a specialty physician. We needed more flexible programs, and we pushed our telemedicine platform to the extent we could, but then we layered on top of it things that we probably couldn't have done without that waiver of HIPAA enforcement. As I was saying before, like running a telemedicine visit and a Zoom visit concurrently on the same computer. Next slide. So telemedicine education, tremendously important. It was important for all those COVID issues, but we've been doing telemedicine education for quite some time at Weill Cornell. Next slide. And why is this education important? Well, a lot of my colleagues who'd never done telemedicine visits before a couple months ago now consider themselves experts in doing telemedicine. This is my hometown newspaper. And this is a title that ran a week and a half ago. And if we could go to the next slide. This is people's self-reports of what happened on business Zoom calls. I'll just give people a moment to read this. So I always personally make it a point to wear pants. However, I have had a couple of these things happen. And some of our education is to reduce this sort of thing, but I think it's more than that. If you could go to the next slide. Presence, being there for people, is an important part of medical care. Developing comfort, and the comfort that flows both ways, a provider comfort and a patient comfort, allows us to replicate some of those same things that can happen in a face-to-face visit over the video. But we're not born knowing how to do this. The ACGME and the AMA have recognized that despite being a digital native, and I have some issues with that term, that we all could learn a lot about how to be professional over the camera and how to do good doctoring and good medical care over the camera. In addition to that, and this will be familiar to many in the audience, some of the medical legal requirements for doing telemedicine are not at all intuitive. My patient who I saw in New York today, who's in New Jersey this evening, if I don't have a license in New Jersey, this is under normal times, not under COVID waiver times, doesn't find it intuitive that I can't see them in the evening when I just saw them earlier in the day. And we need to make providers aware of these medical legal realities, although hopefully some of them will change so that our environment will be more intuitive to all of us. Next slide. So it's one thing to learn what buttons to hit to have a telemedicine visit, but what we our teaching at the Center for Virtual Care is the ability to invoke the engagement, openness, empathy, focus, basically presence that is so often missing in in-person video encounters, let alone or in-person encounters, let alone video encounters. And in addition, this whole area of what you can and can't do over video, what types of examination can be done. We're teaching many elements of general physical exam over video. It's an evolving area of knowledge. Next slide. So we began teaching telemedicine with an elective for medical students starting in 2017. We're now teaching all Weill Cornell medical students telemedicine. We're also beginning to do seminars for graduate learners across the enterprise. We've also, pre-COVID at least, had many visiting students come to us both from across the country and internationally. Next slide. Pre-COVID, we started to do this education in a beautiful space in Midtown Manhattan, lovely Art Deco building. This is one of our in-person education sessions happening in, I think this was January of this year. And we're now engaged in learning how to do the same type of education virtually for obvious reasons. And I'm going to hand off to my colleague, Dr. Neil Nyack, to discuss that a little bit more.
Thank you, Peter. So as Peter said, a lot of what we did in person pre-COVID was already in place, so that way when COVID happened, we were able to transition to the virtual realm and start taking some of these things out of the classroom and teach it in a variety of different ways to all these providers that we were rapidly onboarding across the various programs that we had to institute in a very rapid kind of time period. It was about a 2-week time period that some of these programs got up and off the ground. So I want to start with talking about what we did pre-COVID and how we approached some of this educational educational undertaking, and then get into kind of how this is changing now that we're in a different time. So with our medical students, as Dr. Greenwald alluded to, we started with an elective, and now it is a mandatory part of their clinical clerkship in primary care. We run either 1 or 2 half-day course, a 1 full day or 2 half-day course that is an experiential learning platform for our students. And part of the reason for this is because when we got feedback from our course, we noted that 77%, again, this is pre-COVID, 77% of the students entering the course had never had a telemedicine encounter, and 85% had never had any training in telemedicine whatsoever. And that's a little disconcerting, because that means that there was a group of students that had telemedicine encounters but without any training. But a large portion of students were coming into this with no experience at all. And so what we would do is we would have our curriculum consisted of some didactic to focus on some introductory things, some understanding of what telemedicine is, and then really leverage simulation with debriefing sessions to give them an experience of what it's like to take care of a patient over telemedicine. And we broke this down into just history taking, then added on the physical, and then doing the multiple iterations of different cases. And we got into some of the on-camera presence aspects of it, lighting, framing, how to present yourself as a professional, and also delved into how to do a physical exam. How does that change from what you do in person to the virtual space? And how does your plan change as you move into the virtual space where you're at a distance from your patient? Moreover, we started talking about how to communicate effectively over this platform. Recently, as everyone has kind of had to jump onto the telemedicine platform, there have been a number of editorial pieces coming out about how there's a loss of the personal connection between you and your patient when you do it via telemedicine. And I don't know if I agree with that. I think part of it is that what a lot of people are trying to do is take what they do in person and do it on camera. And that doesn't translate the same way. You can't sit on the edge of the bed the way you would in person. You can't put your hand on your patient's shoulder the way you would in person. But you can do other things that still create the same experience. And so we talk a lot about creating a space in the virtual environment with your patient, a shared space with your patient that is safe for both you and your patient to have a medical conversation and to interact in a way that kind of moves the relationship forward and allows your patient to feel comfortable sharing medical details with you. And that creation of a space is something that takes some skill, takes some practice, and requires some thought. And so those are some of the things that we focus on in this class. And as you can see from the data here, you know, the question, I feel prepared to conduct a telemedicine patient encounter and provide care. There was a rapid shift, or a significant shift in the pre and post questionnaires to people just feeling comfortable after a one-day training experience, a two-day training experience. And so what we started with medical students, we've expanded, talking about basics of telemedicine, website manner, examination skills, and decision-making to over 200 learners, or actually well over 200 learners. We've done training sessions virtually now with students in Qatar. We've done faculty members within our department in emergency medicine, but also neurology, and soon we're going to be doing psychiatry as well. And really kind of broadening the scope of this training to include everyone who potentially could be doing a visit via telemedicine. And this doesn't just include doctors, this includes nurses, residents, paramedics, care managers, PAs, pharmacists, anybody who could be using this technology to provide care in some way is incorporated into our training. We had a session with care managers that you know, a lot of the basics are the same in terms of presenting yourself and communicating effectively, but there's nuance to the field that translates differently from in-person to virtual care. And those nuances are things that come out in a lot of the debriefs after having a virtual experience. So let's dive a little bit deeper into kind of what we do. And so all these encounters, all these simulations that we have our learners go through are recorded, and then in the debrief, we replay some of the videos. So here's an example of something that someone may have done pre-training.
Hi, tell me what's going on.
Hey, I'm having this eye problem on the inner side of this bottom lid. It's been red, a little swollen over the last couple of days.
Fantastic. So that's the opening of the visit. And a provider that's just kind of taking their skills and going onto the video platform, that's a normal way to open a visit. What's going on? But there's issues with this in the sense of the opening of a telemedicine visit has to be slightly different. You're not in the same location as your patient. So verifying that the patient's in a location that you can actually provide care is crucial to that opening introduction aspect of it. The other thing that we tend to forget is all of the nonverbal communication that the patient experiences when they enter a clinic setting. There's a ton of priming that goes on even before they have the in-person interaction with you. They park in a parking lot that has signs that, for us, say Weill Cornell. They get greeted by someone at the front desk that says, "Welcome to Weill Cornell Medicine. Who are you here to see? Dr. So-and-so." They walk through hallways where there's signage, and then they finally get to the room. By the time they get into the room, they know that they're in a medical environment. They know that it's a private location, and they know that they're going to be asked questions about their personal health. And the person that does it is going to be a doctor that's affiliated with this institution that I just walked in. None of that happens when they connect with you from home. They just hop on their phone, and all of a sudden the doctor's on the screen. And if you haven't taken steps to non-verbally prime them in the same way, it can be abrupt, and it can be a little disconcerting if you don't communicate in an effective way. So doing things like, as Dr. Greenwald and I have right now, signage that shows our affiliation. We're both wearing our white coats with our names and affiliation displayed. Wearing your ID so that's actually visible on camera, which is actually up here by the collar, not down on a lanyard in the middle of your abdomen. all these little things go a long way in non-verbally communicating to your patient that we're about to have a professional medical interaction. So I need to make sure that you feel comfortable doing that. And I may verbally reinforce that in the beginning of a visit. As part of my introduction, I'm going to verify name and date of birth of my patient just like I would in person. I'm going to verify their location to make sure I have a license where they're practicing. And if I need to send for help, I know where to send that help. And I'm going to make sure that they're in a safe enough location or a private enough location to have a medical conversation by asking them, are you in a private enough location to have a medical conversation? And seeing if there's anyone else in the room with them. Because all we can see is what is defined by the edges of the screen. Likewise, we're going to introduce ourselves and anybody else who may be on our screen or anybody who may be joining in on the platform. When we had scribes that joined in with our COVID care, we introduced them so that the patient knew very well who was on that call. Ultimately, this is just good patient care. And it makes the patient safe and again, creates that safe environment that allows them to be forthcoming with medical information. But on top of that, there's a second reason that that this is important. Part of that is because a lot of wiretapping laws influence telemedicine law. And in New York is a one-party recording state. So our patient could record us without our knowledge and post it on Facebook if they really wanted to. And so putting our best foot forward, putting our most professional face forward is of utmost importance. It's what we do in person anyways. Why should we not do that when we're on telemedicine? And so this is an example of something that after a training someone may do.
Hello, I'm Dr. Greenwald. Can you see and hear me okay?
I can, yes.
Okay, before we get started, a little housekeeping. Just confirm your name and date of birth for me.
Joanna Flores, 12/23/1995.
Okay, and what location are you calling from today?
50 West Street, New York, 10006.
Okay, terrific. Thanks for confirming that.
Again, doing a lot of those things, setting the stage up front. And these are some of the techniques that we teach our students in how to conduct themselves over telemedicine. An example of the middle of a conversation.
I'm sorry to hear that. Tell me a little bit about your medical history. You're a healthy person?
Yeah, I'd say so.
Okay, and do you wear contact lenses?
No.
Okay, and have you ever had anything done to your eye, any surgeries?
No surgeries.
So in addition to some of those things, we talk about framing and lighting and background. And as you can see here with Dr. Greenwald in the pre-visit, the lighting is causing a glare. There's someone in the background, which may be a HIPAA violation. And there's no way you can tell whether or not he's making eye contact because he's not in the center of the screen. The background takes up the majority of the screen. When staged properly,
so what can I do for you? What's going on?
Yeah, I've had this little thing on my lower eyelid for the last few days. It's a little red, little sore, and just itchy too.
Okay, so I can put that in context. Tell me, do you have any medical problems?
No, I'm pretty healthy.
Okay, do you take any medicines?
Just multivitamin.
All right, and are you allergic to anything?
Seasonal allergies and Robitussin DM.
Okay, what happens with Robitussin?
My lips get very swollen.
Okay, and do you wear contacts?
No, just glasses.
Okay, and have you had any procedures done to your eyes? Any operations, anything like that?
No, never.
Okay, terrific.
And you can see that when you can see his facial expressions because the lighting is clear and the camera is positioned properly, you can start noticing some of the emotion and the empathy that is being conveyed over camera, and your patient feels that as well. These are things that we do with our students as we watch the videos live. So they have the experience, we record it, and then we show it to them in a group setting. And we discuss some of these things and have the students self-critique themselves with their peers to discuss how their individual facial expressions impact the patient and how they may personally change their behaviors to really connect to patients and provide good quality care. Let's watch one more
All
example.
right, let me take a look at your eye. Pick up the phone and bring it close so I can see.
Okay.
Hello? You froze up there for a minute.
So again, we get into physical exam, and while just asking the patient to bring the camera close to their eye may be something that you do, we wanna really kind of fine tune some of these exam skills to really make sure that that providers use their words to instruct their patient adequately how to do the exam that they're requiring. And mirroring and demonstrating for the patient goes a long way as well, which we'll watch here.
Looks like you're talking to me with a phone, is that right?
Yes.
Okay. What I'd like you to do is pick up that phone and get really close to your eye so I can kind of get a close-up. All right. I think the phone could go even closer than that.
Mm-hmm.
Terrific. Can you use a finger here? I'll demonstrate. Can you use a finger to bring the lid down so I can see the inside? Okay, terrific.
And so those little fine tuning, that little fine tuning can improve the exam, improve the interaction, improve the encounter, so that providers are able to communicate the information and obtain the information that they actually need to using this virtual platform. And so when we talk about the future of telemedicine and
Neil,
how
we do have our first question that came in. So since you invited them along the way,
Sure,
this question says, our providers report that frustration on both sides of the screen in navigating the platforms is preventing them from ever getting to the core issues of website, quote unquote, manner, often defaulting out of a telemedicine platform to audio only or deferring until in person. Do you work on how to get past this barrier?
Yes. So inherent within these discussions, that exact question comes up almost every single time. And one of the things that we have to admit as telemedicine providers and telemedicine educators is that if your technology doesn't work for you, it's very difficult to have these interactions. So one of the things that we instruct our students we help our students understand is what are the technical requirements, upload, download speeds, what latency and lag are, so that they have an understanding of what is causing their connection to maybe not be as optimal. And then we talk about techniques to optimize this both before the encounter and then troubleshooting techniques during the encounter. And one of the reasons to understand this is so that you can also instruct your patient how to troubleshoot things on their end. Things such as a lot of times we have our patients calling in on phones and they're pacing around their apartment. Well, that pacing, if they're connected to a Wi-Fi signal, creates fluctuations in their connection. So having them stand in one spot or finding a location that is the optimal connection and then setting their phone down so there's not any movement with that phone can help that encounter. Understanding how to adjust the audio on your side and your microphone on your side, and maybe being able to instruct the patient on their end how to adjust those things as well. So little troubleshooting things like that, we definitely include in our teaching so that I think makes providers just more comfortable when they have that knowledge that the connection isn't going to be lost and they have options to go to, and that prevents them from just flipping to a video visit or a phone visit without even trying anything. But two, I think having that understanding just makes you more comfortable on the video platform or on the virtual platform. And that in itself is beneficial. Peter, do you have anything to add?
I'd just say oftentimes in our clinical environments, we're stuck with the platform we have. And some of these platforms are, to be perfectly honest, inadequate to the task. On the development side, we need to do a much better job with user interfaces, both on the patient side and on the physician side. It's one thing that's been particularly telling with this waiver of HIPAA enforcement as people have used commercially available software to do telemedicine visits that is just less clunky and works better. And there's no reason we can't have that in medicine. And if telemedicine visits are 14% of patient interactions, or at least were in April, I'd say it's a real imperative that we do that and do that quickly.
I think the one other thing that is going to influence that going forward is when it's easy to switch over to a different modality, or it's easier just to tell the patient to come in to the clinic for a visit in person, you don't put as much effort into troubleshooting it. When there's actual risks of having the patient come in, or there's time that it takes for the patient to come in, it gives you more of an imperative to troubleshoot the audiovisual in real time. And I think that's something that we may have seen over the last couple of months as well.
And to tie this into education, which is the point of our talk, right? I think setting providers up with success experience by giving them enough education in how to conduct these visits and seeing what it can be like when things go properly will give people the motivation to persevere a bit. If you already know it's not going to work and then it doesn't work 3 times in a row, I think you're done and you walk away. And we need to prevent people from falling into that position.
And another question that's come in related to part of your response is about how to teach methods of doing informed consent. Is your standard for that to be done by the scheduler?
Peter, I'll let you take that one.
I'm sorry, you're going to take it?
I'll let you take that one.
Yeah, so the majority of our patients are in New York State, although we do see patients in Connecticut, New Jersey, and Florida. And verbal consent is acceptable in those areas, not written consent, thankfully. Patients are joining us in most of our platforms of their own accord. It's a virtual urgent care service. So in my clinical environment, the patient has already initiated the visit and plans on doing a telemedicine visit, and that was their intent all along. So verbal consent is not too much of an issue. For the general folks that we train, getting verbal consent is done in a system-dependent fashion. We recommend that people make sure that patients are willing to do a telemedicine visit and inform them of their options to do care in person. As I think Dr. Nayak was alluding to, part of the tremendous increase in virtual care volume that we've seen is because people are not willing to be seen in person because of a presumed threat. In my clinical environment, in the express care model, in the ED model, that consent is taken care of during the triage process. So I guess that would be the equivalent of the scheduler doing it.
As consent was brought up, one of the other things that we definitely address and discuss in a lot of our courses is consent for private examinations. And I don't know if there's any legal, what the legal landscape of this is, but one of the things that we definitely want to discuss and make sure people are aware of is that, yes, even with the initial consent, they may be willing to have a telemedicine visit and provide care. But I think it's very important that if part of the examination requires some sort of private exam or perceived private exam, I should say, a secondary verbal consent should be part of that to ensure that both the patient and the provider are comfortable with that exam taking place on camera. And if not, discussing ways that maybe the exam could be done off camera and reported back to the provider, or it may require the patient actually come in for an in-person exam. But I think that level of consent may be important in some of these visits, and it's something that we discuss with our students as well.
And one further question has surfaced you were talking about eye contact a little back when you were showing the video. So this comments that eye contact is being lost these days with EHR use by the providers, and so the same issue with virtual care. Do you provide tips on dealing with that issue in your training?
Yes, and in a lot of our training, that is probably the hardest thing to train people to do, understanding that eye contact is looking into the camera, not looking at the screen. And in-person practice with EMRs, there is loss of eye contact as well. But on video, it's even harder because we need to look at our patient's face to understand a lot of the communication that they're having non-verbally and the expressions that they're showing on camera. If they're grimacing, that tells us a lot. And so it's not even a balance, virtually, it's not even a balance between looking at the computer to document and making eye contact and looking at the patient. It's making eye contact and it's making eye contact with the patient or looking at the patient. And that becomes challenging. And so one of the things that we talk about revolves around making eye contact with a purpose. So when you want to show that you are listening to the patient, making eye contact and looking into the camera is important. When you want to show the patient that you're making, or when you want to demonstrate to the patient that what you're saying is an important piece of information, making eye contact into the camera is an important part of that. But realizing that even in person, we don't constantly make eye contact with the patient, we can look away and look down at the screen. The other part of that, and a lot of what we teach, is how verbal communication can make up for nonverbal communication in the virtual space. So I may be documenting while having a virtual visit. And in the beginning of the visit, if I let my patient know up front, just so you know, you may see my eyes look over to the left. That's just me looking at my other monitor and making sure that I'm just taking notes to make sure I don't miss anything. A quick statement like that in the beginning of the visit all of a sudden normalizes it for the rest of the visit. Whereas if you don't say those things, the patient notices your eyes going all over the place or even your head turning, and the impression is that you aren't listening to them. Similar to what happens in the clinical space as well.
And one further question, would you please offer more information about involving a scribe?
Peter, you want to take?
Just coming off mute. Yeah, using scribes has been a tremendous advantage for our virtual offerings through the emergency department in this last couple months. And this is one of the areas where we've made liberal use of that HIPAA waiver of enforcement. We are currently running a Zoom session simultaneous with running telemedicine visits on the platform that we've always used. And in that Zoom visit, we share audio and share the screen. There's no need to share the camera because the scribe then sees what's on the screen. The scribe is remote from the provider and captures the medical information during the visit. As Dr. Nayak said, we disclose the presence of the scribe at the beginning of the visit. You know, as part of that housekeeping, you heard me simulate with Ms. Flores there. We include, just so you know, there's a scribe who's part of this conversation. Or can hear this conversation, although they won't be taking part. Is that okay with you? If the patient indicates no, the scribe clicks off for the remainder of the visit. If the patient, which almost always is the case, says that's fine, then we continue on. So the scribe is sort of a silent passenger throughout the visit. Also very helpful, some of that clunkiness, I think I used that term before, in our video platforms. Hopefully whatever shop you work at is slightly better integrated with the EMR, ideally the video visit within the EMR itself. We're not there yet, although we're getting there. Having the scribe helps us overcome some of that difficulty associated with needing to have multiple programs up and running and multiple screens running at the same time.
So Neil and Peter, we have 7 minutes left in the session. Would you like to continue taking questions? We do have a couple, or at least one more that has come in, or would you like to proceed with your prepared presentation?
Let me just finish real quick, just a few other slides, and then we can go back to questions.
Great.
All right. So one of the things that we're thinking about now is, as COVID has happened, how is that changing not only how we provide telemedical care, but also how do we have to train our providers differently? How is the training going to change? One of the things that enabled us to onboard and train so many people during the pandemic, or who were coming on from different specialties and had never done telemedicine before, was the fact that we already had a training program set up. And so we knew what we wanted to teach. We couldn't do it in person the way that we had before. And given the scale, we couldn't necessarily run simulations for everyone. And so as Dr. Greenwald said, we kind of had this live mentoring telementoring kind of setup, where one of the seasoned providers who had gone through our course and understood the importance of a lot of these things joined in with one of the new providers and could give them real-time feedback on their visits. And this enabled them to one, yes, to learn the platform and the technical aspects of running a telemedicine visit on the platform, but also kind of gave them a lot of this information about how to be professional, how to present yourself, how to create a shared space between you and your patient. It enabled us to transmit and translate a lot of what we had taught before into the new learners coming on board in a rapid method. And so as we think more, as we go forward about how this in-person care and virtual care are going to kind of merge together, what we need to realize is that telemedicine is not meant to replace in-person medicine. And a lot of providers that kind of started using telemedicine in the last couple of months, that has been their experience with what telemedicine has been, because that is the way it has been used. We couldn't provide in-person care the same way, and so we've substituted telemedical care for that. But the reality is, going forward, these two need to play together. It should be a continuum between in-person care and virtual care. And understanding that allows people to understand the pros and cons of both. The fact that a patient invites you into their home with a telemedicine visit is of great importance, and you can glean a lot of information, especially for a primary care doctor or a psychiatrist, a nutritionist. You have the ability to look in their fridge, which you never do if you're meeting in an office. And so if we start having our learners understand this interplay, they can start thinking more critically about how to utilize telemedicine and what it takes to create this safe virtual space between you and your patient. And so what has happened is, we've taught a lot up to this point about how our medical decision-making changes within telemedicine because our patient is at a distance or not directly in front of us. And so we have more options or more nuance within our medical decision-making. But we also need to start thinking about how telemedicine is changing medical decision-making. The program that we had during COVID, where we sent patients home with O2 sats of 91% with some equipment and a telemedicine visit the next day, that's something we never would have thought of doing before telemedicine. And so telemedicine gave us the ability to do and provide care this way. And so our medical decision-making is changing because of telemedicine. And this is how telemedicine can start being leveraged in new and fascinating ways. And if our learners start thinking critically about this, about what telemedicine is, how we can leverage it, and how it improves care, we can start seeing both growth in individual providers in creating this safe space with their patient, the shared space where that emotional connection is still there, and also the development of telemedicine as a whole. And so while we've talked about how technology solutions are important for effective telemedicine use, workflows are, institutional support, patient and provider readiness, which is now there. Training is actually a huge part into making telemedicine as effective as it can be going forward. And while a huge part of, while a part of the training is to make sure that we don't end up in the New York Post, I think what's more important is this training is critical because we want to make sure we do this right. We now have, pre-COVID, we had a lot of people, we had people using telemedicine who are interested in using it and interested in learning. We now have a large cohort of providers who are doing telemedicine and now need to go back and say, even though I think I'm an expert, maybe technically I know how to use the platform and I can definitely conduct a visit, but am I doing it the right way? And so we need to kind of take all of that entire cohort of providers and say, okay, we now need to train you on how to do this right, to make sure that we're providing the same quality of care over telemedicine that we do in person. And that's going to be, I think, the challenge of telemedicine education going forward. Thanks. And now we'll go back to the questions.
Fantastic. We have one so far. So folks, we have actually just 2 minutes left, so there's probably only time for this last question. Do you assess for competencies of medical students? I assume that means telehealth competencies. And do you have a tool helpful for others pursuing training programs?
Okay, so that's a huge question. Telemedicine competencies, I think, is something that's being discussed right now. I think, the challenging part of coming up with telemedicine competencies is making something that is useful, but also broad enough that it's not just meant for an emergency physician. It can be applied to everyone greatly. So those are things that I think are being developed and definitely being discussed on the national level. Do we need to have, what are the competencies? And do we need to make sure, going off of that, is there a minimal requirement of training that should be necessary to provide visits? I don't know if I have the answers to that. I think it's going to be an interesting discussion going forward. And I think the way that, the next couple of months play out with regard to, next couple of years with regard to regulation and reimbursement and the growth of telemedicine as a whole may influence how much is required of training. The second part of the question was
whether or not you have a tool that you could share.
Watch this space.
Yeah.
It's coming.
Yeah. I think there's a lot of people that are developing tools for are thinking about developing tools for evaluating students, learners with regard to telemedicine. I also think there's a large number of educational things that are that are coming online as well. Since we're all remote right now, the online module seems to be the way that we're teaching a lot of stuff. I think the challenging part about online modules is it presents a lot of knowledge, but you don't get that experiential component to it. And so figuring out how to translate that, maybe how to include that into modules, how to incorporate maybe telesimulation. Personal plug as a simulationist, maybe including telesimulation as part of these training modules or curriculums is going to be really interesting to see. And I think that's where education is going to evolve.
Now, with all due respect to Neil, who's currently engaged with participants from other academic medical centers in developing just such a tool, when we eventually do have a checklist, I think we should all remember that part of what we'll be assessing is our ability to fit the cultural perception of what a provider should be, and that might vary depending on who the audience is. And I think in the times we're living in right now, we need to be cognizant and cautious about that.
Well said, and that's a great end note. We are at the end of our presentation, and so Dr. Greenwald and Dr. Naik, that was terrific. I knew it would be. Thank you so much. And everybody, please don't forget to provide feedback about this session through the conference app. I know the telehealth resource centers will really use that to make events in the future even better. And I thank everyone again for being here. I hope you have a great rest of the afternoon.
Yeah, let's find a way to do this in person in 2021, huh?
Please.
Thank you, everyone. Take care.